Mhm.
Hello, everyone. Welcome to the Audio Learner. This is going to be the second video made for people who, required auditory learning. Um, this video is going to be about uh, care for special needs patients. We will be first going to talk about anxiety, then multiple sclerosis, then asthma, and then Parkinson's disease. All right, so let's get into the very first one. Let's talk about anxiety. What's the definition of anxiety? Best defined as a sense of psychological distress that may not have a focus. It's a state of apprehension, a vague sense of worry, uneasiness, or dread that may involve an internal psychological conflict or can be caused by an environmental stress, physical disease state, medicine or drug effect, or a combination. It is a natural response, necessary warning adaptation in humans when a person's bodies, lifestyle, values, or loved ones are threatened. It becomes pathological, though, when it is excessive and uncontrollable and requires no specific stimulus and results in physical and affective symptoms and changes in behavior and cognition. All right, anxiety disorders. We got panic attacks, which is when a person has repeated panic attacks described as having a panic disorder, usually lasts for about 20 to 30 minutes. Then there's phobias. There's three major groups of phobias. There's agoraphobia, which is a fear of having distressful or embarrassing symptoms of leaving home. So a fear of being alone in public areas. So that can cause them to be homebound for years. There's social phobias, which are more specific to things such as public speaking. And then there's a simple phobia, which is fear of snakes, heights, flying, darkness, needles, claustrophobia, things like that. Or previous, frightening dental experiences. There's also PTSD, post-traumatic stress disorder. And then there's generalized anxiety disorders like fear of health and safety, anxiety about being late, fear of dark, performance anxiety, or stage fright. Clinical signs of anxiety are xerostomia, difficult in swallowing, like a lump in the throat, shortness of breath, muscle tension, trembling, breathlessness, sweating, nausea, dilated pupils, frequent urination. Common treatments and modalities for or medications for anxiety. There's a psychological treatment, psychotherapy, which is used in severe cases. There's behavioral treatment that approaches a more cognitive aspect like hypnosis, desensitization, where the patient is gradually exposed to the fear situation. And then there's flooding, when the patient is exposed directly to the anxiety provoking stimulus. There's drug modalities, common drugs, which and systemic implications are benzodiazepines that slows the activity of the limbic system, which is the control for emotions. Then there's tricyclic antidepressants, which blocks the reuptake of serotonin and norepinephrine and dopamine, and then increases the neurotransmitter levels and mood elevation. Then there's psychoneurotic drugs like SSRIs, which increases the serotonin, which then increases the mood. Then there's monoamine oxidase inhibitors, which increases serotonin as well, norepinephrine and dopamine in the central nervous system, which then stimulates and elevates mood. There's antihistamines, there's beta adrenergic receptor antagonists, and then there's sedative hypnotics. Management and special caution for the patient in the dental setting. So you want to obtain an accurate medical history, including medication regimen. Patients with anxiety may be reluctant to admit their use of medications. You want to ask the patient for medication updates at each appointment. You want to be supportive and non-judgmental. Patients with anxiety disorder commonly associated with mitral valve prolapse. So the current AHA guidelines do not recommend antibiotic prophylaxis for mitral valve prolapse. Okay, thank you, Lisa. Consider artificial salivary products for patients with xerostomia. Social and psychological barriers, neglect of oral hygiene leads to an increase of risk of dental caries. There's poor nutrition and avoidance of necessary dental care. Those are the barriers. Necessary consultations with severe anxiety, the patient's physician should be considered regarding any special management. How should these dental services be conducted? What should you do in the dental setting? You want to establish effective communication. You want to provide explanations for procedures with short question and answer breaks to address the concerns. You want to reassure the patient that all possible measures for a pain-free procedure will be used. You always advise the patient beforehand of possible complications that could occur during treatment, and there might be possible administrations of nitrous oxide. What you don't want to do is you don't want to intimidate your patients. You do not want to instigate fear and stress. Vasoconstrictors like epinephrine and levonorepinephrine should be used cautiously on patients taking tricyclic antidepressants due to the risk of depressor effects, which include elevation of the blood pressure. So people taking tricyclic antidepressants for anxiety, vasoconstrictor might be a contraindication. Also, if they're taking tricyclic antidepressants. And also, you don't want them to be upright position of the patient in the dental chair if they take tricyclic antidepressants, monoxidase inhibitors, or antipsychotics. Slow positioning changes and or monitoring of pressure may be indicated. Okay, so that's for anxiety. Upright position of the patient in the dental chair. If they're taking tricyclic antidepressants, do not put them in supine. Slow positioning changes and monitoring of blood pressure may be indicated. Okay, so that's anxiety. Kind of a straightforward thing. Now let's go into multiple sclerosis. Okay, so what is multiple sclerosis? It's the most common autoimmune disease of the nervous system, second only to head trauma as the leading cause of neurological disabilities in young adults. It is characterized by chronic and continuous demyelinization of the corticospinal tract neuron in two or more regions of the brain and spinal cord. So demyelinated regions are limited to white matter of the CNS, and the peripheral nervous system is not affected. Okay, this is Lynn. All right, Lynn. Signs and symptoms. Signs of MS often appear in young adulthood. Manifestations vary according to the region of the CNS involved, to the degree of the disruption of the myelin sheath. There could be disturbances in visual function, abnormal eye movements, and abnormal eye movements, which are the most common manifestations. Motor disturbances, walking and use of hands, as well as loss of balance. Sensory disturbances, such as loss of touch, pain, temperature, proprioception, are common. Fatigue is a major symptom in 90% of cases. And repeated attacks can cause permanent physical damage. However, intellectual function remains intact for MS patients. There is the categories of progression for MS are relapsing, primary progressive, secondary progressive, and progressive relapse. So again, MS is a damaged neuron, damaging the myelin sheath. The immune system is attacking the myelin sheath of the neurons. Depending where that neuron is, that's how it's going to manifest physically. Treatment. There are many complications for MS that require treatment with several drugs. Patients with relapsing forms of MS are giving anti-inflammatory medications. Interferon beta 1b injections slow down the progression of disease. Medication also suppresses T cell attacks on the myelin sheath and are used during periods of remission to reduce the clinical relapse. Mitaxantrone is reserved for patients who have aggressive disease. Let's see, spasticity is managed with antispastic drugs such as baclofen, benzodiazepines, dantrolene, or tizanidine. Fatigue is managed with afternoon naps, exercise, and amantadine, Symetril, or modafinil. So the drugs, the primary drugs are interferon beta A, interferon beta B, 1A, 1B, and natalizumab, transient fluid-like symptoms caused by that one. If there are more severe forms, it's glatiramer acetate injections and mitoxantrone infusions, which can cause pretty bad things such as leukoplakia, ulcerative stomatitis. Oral signs and symptoms of MS. MS are reported to occur in 2 to 3% of affected persons. So the most common features are dysarthria, which is slow, irregular speech with unusual separation of syllables, paresthesia, numbness of oral facial structures, and trigeminal neuralgia. Sudden, severe facial pain is 400 times more likely among persons with MS than among the general population. During an attack, the patient may feel facial paresthesia and muscles of facial expression and can undulate in wave like motions. So, how do you manage a patient with MS? Patients experiencing relapse are unfit to receive routine dental care. Emergency dental care can be provided, but is affected by the medications the patients take. Physicians should be consulted before emergency dental care. The optimal time for treating patients with MS is during periods of remission. Uh, let's see here. Also, because fatigue is often worse in the afternoon, short morning appointments are advised. Patients with stable disease, little motor spasticity or weakness can receive dental care. A lot of their medications can cause dry mouth. There are social barriers. Finding an office that is sufficiently accessible. People with MS, are disabled and likely not to complete high school. Psychological barriers, cultural barriers, hereditary, social cultural factors, their anger, joy, environmental factors, climate, infection, diet, distress. Okay. So what should you do with people who have MS? You should give them short morning appointments and use people language first. So people language is people with disabilities. You don't want to call them handicapped or disabled people. Another example is that this person has a developmental or intellectual disability. You don't want to say the person is mentally retarded or a mongoloid. So these are people first language. Again, you want to say the patient uses a wheelchair. You don't want to say the patient is wheelchair bound. You want to say the patient has a physical disability. You don't want to say patient's a crippled. You want to say person of short stature. You don't want to say the person's a midget. You want to say they are hard of hearing. You don't want to say they suffer from hearing loss. You want to say person without a disability. So you want to say that. You don't want to say they're normal, healthy people. You do want to say accessible parking or bathroom. You don't want to say handicap parking or bathroom. Anyways, continuing forward, patient management, they have visual disturbances, motor disturbances. Okay, that was whack. It's all right. At least we got an idea. Multiple sclerosis, morning appointments, short appointments, myelin sheath, autoimmune disease. They can have dysarthria, paresthesia, or trigeminal neuralgia. Dysarthria is slow speech, irregular speech. Paresthesia, numbness of oral facials. Trigeminal neuralgia is sudden, severe facial pain. There are social, psychological, and cultural barriers, and you want to give them short morning appointments. Also, don't be annoyed if they are offended when the patient. Don't be annoyed or offended when the patient loses concentration. All right, let's go into asthma. All right, so let's run this down. Severe asthma is also COPD. So COPD and asthma are respiratory diseases that are common amongst the general population. It's important for hygienists to understand the respiratory diseases and the medications that they use. The most frequently encountered respiratory diseases are asthma and COPD. COPD is a chronic inflammatory lung disease that causes obstructed airflow from the lungs, caused by long-term exposure to gas, particulate matter, most often from cigarettes. Cigarette smoking is the major risk factor for COPD. People with COPD are at increased risk of developing heart disease, lung cancer, and other conditions. Emphysema and bronchitis are the two of the most common conditions that contribute to COPD. These two conditions usually occur together and can vary in severity. So emphysema is when the inner walls of the lungs, of the air sacs or the alveoli are damaged, causing them to eventually rupture. This creates a large airspace instead of many small ones and reduces the surface area for the gas exchange. Bronchitis is an inflammation of the lining of the bronchial tubes, which carry air to and from the lungs. People who have bronchitis often cough up thick mucus, which can be discolored. So that's emphysema and bronchitis. Chronic obstructive pulmonary disease is the third leading cause of death in the United States. It affects approximately 5% of adults, 10% of persons older than 45. The most important cause of COPD is smoking. 12.5% of current smokers, 9% of former smokers, 8% of those exposed to passive smoke. The onset of COPD takes many years. It usually begins after the age of 40. Signs and symptoms of COPD: shortness of breath, dyspnea, wheezing, chest tightness, frequent respiratory infections, lack of energy, unintended weight loss in later stages, swelling in the ankles, feet, or legs. Interesting. Could be, that sounds like, that last one sounds like congestive heart failure. Anyways, so there are 4 stages of COPD, and it's measured by forced vital capacity, and how much expiratory volume in 1 second is determined by a spirometry meter. So there's mild, moderate, severe, and very severe. Drugs commonly used for treatment of COPD. Although it's an irreversible process, there is no cure for COPD. Management includes smoking cessation, avoidance of pulmonary irritants, influenza, and pneumonial vaccinations. Okay, so COPD shouldn't get influenza or pneumonial coccal vaccinations, and use of short or long-acting bronchodilators. So avoidance of pulmonary irritants, influenza, and vaccinations. Interesting. And use of short and long-acting bronchodilators. So they should use an inhaler. They shouldn't get vaccinations. Other recommended measures are improving exercise tolerance, nutrition, and adequate hydration. So here we are, bronchodilators. Medications that are used usually come in inhalers. They relax the muscles around the airway and relieve coughing and shortness of breath. And depending on the severity, you may need short-acting bronchodilator before activities, long-acting bronchodilators that you can use every day, or both. So short-acting bronchodilators are albuterol, levolbuterol, and ipratropium. Those are short-acting. Long-acting bronchodilators are aclidinium, arformoterol, formoterol, indacaterol, tiotropium, salmeterol, and umeclindium. So drugs that are used for COPD are inhaled steroids, inhaled corticosteroids that reduce airway inflammation, pulmonary rehabilitation programs generally combine education, exercise, and nutrition. They can also have oxygen therapy. If there isn't enough oxygen in your blood, they may need supplemental oxygen. That sounds bad. A lot of stuff about COPD here. Just be very aware of the manifestations of it. Oral complications and manifestations of COPD are halitosis, tooth stain, nicotine stomatitis, and oral cancers. Especially if they're smokers, they have a likelihood of periodontal disease and mucosal lesions. Poor oral hygiene all contributes and exacerbates all the COPD symptoms. They can also have oral candidiasis, tooth erosion due to gastric reflux, and of course, xerostomia. Before initiating dental care, clinicians should assess the severity of the patient's respiratory disease. Patient coming to the office for routine dental care who displays shortness of breath, a productive cough. Dental care can be provided to patients with stage 1 or 3 COPD, but should not be provided in patients who have stage 4. So you could do care stage 1, 2, and 3, but not stage 4. It is important to know the patient's history of attacks. Patient may be asked to do a spirometer test to check their expiratory volume. If it's a 10% less than baseline, they may discontinue appointment. There are special precautions. Patients should bring inhalers to every appointment. Some patients with asthma are sensitive to epinephrine, so avoid it when possible. Patients with COPD should be kept upright or semi-supine. Shorter appointments or breaks in appointments should be provided. Extra caution when using dental materials with powder and avoid air polishers. You definitely want to know what the physician has to say about the patient's COPD, especially if it's not controlled. And patients are, if they are open to smoking cessation, we could provide that. So do's and don'ts for COPD. Do assess the medical history for triggers, severity, and medication. Check the patient to that they took their regular dose of medication. Keep appointments calm and patients relaxed to minimize attacks and have easy access to an inhaler. Do not have a COPD patient in supine, very similar to multiple sclerosis. Do not use epinephrine or an air polisher, okay, and do not create a stressful environment. Okay, last one for this video. We're going to talk about Parkinson's disease. Parkinson's disease is the second most neurodegenerative disorder after Alzheimer's. It increase in incidence with growth of an aging population. So what is Parkinson's disease? It's a chronic progressive neurodegenerative disorder of the motor system resulting from the loss of dopamine producing neurons, meaning that it affects the nervous system and parts of the body controlled by the nerves, and it gets worse with time. So we do not know the etiology of Parkinson's, but is believed to be linked with a genetic and environmental factor. Genetic cause is about 10 to 15% of all Parkinson's. Environmental factors include head injuries, areas of residency, and exposure to pesticides. So it sounds like that's the bulk of why people get Parkinson's. There's adult onset, young onset, and juvenile. Adult onset is the most common, which is people of 60 years old or older. Young onset is 20 to 40. Juvenile is before the age of 21, which is rare. Men get Parkinson's more than women, 1.5 times more. Signs and symptoms of Parkinson are motor symptoms. The motor symptoms, which are slow movement, rigid muscles, frozen facial expressions, tremor, difficulty rising from sitting in position, difficulty writing, stooped posture with flexed arms. Non-motor symptoms are anxiety, depression, vision problems, loss of sense of smell, sleep disturbance, apathy and fatigue, speech problems, constipation, burning mouth syndrome. Parks, postural instability, anxiety, rigidity, kinetic problems, shaking. Signs of Parkinson's. Stages of Parkinson's. Stage 1, they develop a mild symptoms but able to go about day-to-day life. Stage 2, symptoms such as tremors and stiffness begin to worsen. Poor posture. Stage 3 is movement begins to slow down and loss of balance. Stage 4, symptoms are severe and cause significant issues with day-to-day living, unable to live alone. Stage 5 is walking or standing is impossible, and they are confined to a wheelchair at stage 4. Symptoms start to emerge after 80% of dopamine neurons depleted. Progression of disease is unique to each individual. Common medications and treatment for Parkinson's. There's physical therapy, there's drug therapy, and then there's surgery. Physical therapy is to increase dopamine levels in the brain. So physical therapy provides patients with safe methods from rising from the chair, walking, climbing stairs, and combating immobility. Drug therapies, each individual utilizes a variety of drugs based on anticipated adverse effects and complications. There's 6 types of drugs that they can use: anticholinergic, monooxidase B inhibitors, levodopa, dopamine agonists, and catechol-O-methyltransferase inhibitors, and amantadine, kind of similar to what we spoke about before. Surgery, replacement of dopamine neurons via grafting of fetal nerve tissue, antioxidant injections of trophic factors, deep brain stimulation of subthalamic nuclei, thalamotomy or pallidotomy. There are some adverse effects, especially for some of these drugs. Most of them are in the mouth, are dry mouth. Um, the adverse effects sometimes are also sedation, urinary retention. Um, so these things mimic dopamine. Um, some of them also interact with erythromycin, such as this long name here. Monooxidase inhibitors prevents metabolism of dopamine, and neurotransmitter inhibitors, amatidine. So they can have sedation, urinary problems, edema, nausea, confusion. Okay, signs and symptoms of Parkinson's in the mouth. Excessive salivation and drooling, dysphagia, decreased frequency of swallowing, muscle rigidity leading to poor oral hygiene, xerostomia, poor denture retention, increased decay of teeth, and burning dry mouth. So, management of people with Parkinson's, you want the scheduling of appointments. Patients should receive dental care during the time of day at which their medication has the maximum effect. It is generally 2 to 3 hours after taking it. Recall appointments scheduled off the patient's ability to keep oral cavity cleansed. So I guess scheduling appointments depends on when they took their medications. Should be 2 to 3 hours after taking it. Chair positioning. To reduce the likelihood of a fall from the dental chair, the patient should be assisted to and from the chair. At the end of the appointment, the chair should be inclined slowly to prevent orthostatic hypotension. For anesthesia, it is advisable to limit the dose of epinephrine to 2 carpules containing 1 to 100 epinephrine in patients who take COMT inhibitors to prevent toxicity. Medical precautions: there is no need for antibiotic prophylaxis. The presence of tremors or coriform movements may warrant the use of soft arm restraints. Um, Management and special precautions dental office. Oral hygiene instructions. You must give proper oral hygiene instructions to these people, provide alternative aids such as Collis curved toothbrushes that help both the patient and their caregiver if they have one in making oral care efficient. Also, biotine for dry mouth. There are social, psychological, and cultural factors, barriers. You definitely want consultation and referrals before dental treatment. Dental can play an important role in recognizing symptoms of Parkinson's disease and make referral to the patient if they see make a referral for the patient to see their physician. For patients in stages 1 to 3, most dental treatments can continue. For patients stage 4 to 5 with uncontrolled tremors, they may need to have their dental treatment done under sedation. All right, so here we go. So always for Parkinson's, review medical history. Ask if they're taking experiencing any adverse effects from their medications. Assess the dexterity. Change the chair position slowly. Schedule the patient at the time that they have taken their medications. Provide OHI to both the patient and their caregiver. Never start treatment without reviewing medical history and vitals. Never change chair position quickly. Never provide anesthesia more than limiting dose of 2 carpules of 1 to 100 epinephrine. Never start treatment on a patient who hasn't taken their medication, and never continue any treatment if tremors start to occur. Whew, okay, so that was 1, 2, 3, 4 conditions. That was anxiety, multiple sclerosis, asthma, COPD, and Parkinson's for dental care for special needs patients. Thank you very much.